Hey everybody, welcome to today's webinar. My name's Professor Chris Bain, Professor of Digital Health at Monash Uni, and I'll be leading the session today. We've got some fantastic speakers for you, some very experienced people, all of whom have a strong industry focus, sometimes a little overlap into academia as well. The title for today's session is From Innovation to Industry to Impact, Translating Digital Health R&D, and whilst obviously research and R&D are a key part of this, so too is the needs of the workforce in the healthcare system and in the health tech industry to help advance the agendas of digital health. And we'll be covering both of those things in today's session. And I'd just like to acknowledge that Monash Uni recognises that its Australian campuses are located on the unceded lands of the people of the Kulin Nations, and we'd like to pay our respects to their elders past and present and emerging. There will be an opportunity for everybody to be asking questions through the chat function later on in the session, and I have some assistants in the background who help guide us through that. The first part of the session today, though, is me giving you a little bit of an introduction, and then I will hand over to each of our speakers in turn. You have about 15 minutes to talk about their perspectives and experience on these issues. When that's finished, we'll have a short 5-minute break. We'll come back for a panel conversation and then also direct questions from the audience as well. So I am the Professor of Digital Health in the Faculty of IT. My background is heavily in industry for 27 years in medicine and IT, but then in the uni in the last 9 years, and I have quite an atypical role. A lot of it is outward facing, a lot of it is engaging with industry. Hence, I know all of the people on the screen today through that mechanism to provide better opportunities for our researchers in terms of generating research, in providing pathways for their outputs, but also in helping training into industry and providing placements for our students into industry as well. So with that in mind, just a bit more about the Faculty of IT. So we are the only standalone Faculty of IT in Australia. I'll keep saying that till somebody says we're wrong, but we actually believe that to be quite true. We're very highly ranked internationally, in the top couple in the country, and then accordingly highly ranked internationally. Anything you can think of in relation to IT, we cover it in our faculty, from very technical people to very socially and ethically oriented people when it comes to their work. And we do this across 3 departments, so data science, human-centered computing, and then software systems and cybersecurity. And we also have 2 overarching topic themes that run across those departments, and one of those is digital health that I lead, and the other is around the environment and energy and related issues. We have the largest permanent data science group in the country in a university, we believe. We also have really internationally known people in areas like assistive technologies, using technology to assist people with various kinds of disabilities and impairments. We also have a very strong embodied visualization group, which deals with things like VR, AR, and novel ways to visualize data. We have a dedicated Associate Dean Enterprise and Impact role, plus a separate Associate Dean Innovation, which is a newer role, and an Associate Dean and Deputy International. And part of their work is also about getting translation into the real world and building bridges with industry, not just about transnational education. And as you'll see in a minute, we have a very long history of quite successful industry engagement, both in formal and informal ways. Something we've been doing more recently in the last 12 months is as a member of AND Health. But there's a lot of other ways we've engaged with industry, and I'll just briefly share those now. This is one of our major research projects, happened to be funded by the Digital Health CRC in conjunction with us and other partners, but was partnered with the industry partner, that being Health Direct Australia, and with end users from scratch. And because of that, the tool that has come out of this, the patient consultation summary tool, is already embedded into the Health Direct Australia telehealth platform, and agencies are able just to start using that if they wish. There is parallel work going on to make an even better, an ongoing version of that, especially in the setting of more and more AI capability. And another major project, again, happened to be funded through the digital CRC mechanism, was with Eastern Health, but it's now rolling out to other sites like Peninsula Health, again, designed from the ground up to meet industry needs. And this was about building dashboards and reporting mechanisms to move national standards accreditation much more towards automated reporting rather than a lot of ad hoc analysis. And this has also been quite successful. We have a program called the Industry-Based Learning Program, which I believe has been going for a couple of decades. Suma, who you'll hear from in a little while, has actually signed up her department to participate in this year. This program is for the upper end in terms of performance of our undergraduate students. They may have single degrees or double degrees with us. And each semester, there's probably 100 to 120 students who are placed into IT functions and departments in different kinds of organisations. And I'm really excited that this year we actually have a dedicated health cohort. So I've previously personally been supervising people at Qantas and Jetstar and car sales, and it's all wonderful and interesting, but I'd much rather be mentoring these people whilst they're also situated in the health industry. We also have a different scheme, which is a non-paid scheme where we have literally about 150 student teams across the undergraduate and postgraduate space every semester, where these students will work in a team on a project with an industry partner or using industry available data to try and solve some sort of a problem. So this is, again, something that people in industry, and I mean, be that the health industry, the technology industry, or any intersection industries, can engage in these things as well. And there'll be more information later through the chat and other means for you to inquire about it if you wish to. So that's enough about me. I'd like to move on to our first speaker. I'm going to stop sharing and allow Angela to share her screen. And while she does that, I'll just introduce Angela, who's someone I've known for probably a couple of decades now. Angela Ryan is a lead healthcare executive across Japan and Asia Pacific for Oracle Health. And Angela is a registered nurse, a health informatician and executive with extensive experience across the health system. She has led policy reform and large-scale programs at the state and federal level in digital health. She, as I said, is a lead healthcare executive with Oracle Health and holds board roles with the Australasian Institute of Digital Health and Therapeutic Guidelines. And aside from all that, she's a lovely person and highly collaborative, which is important as well. So with that, I will hand over to Angela to share some words with us.
Great, thanks. And Chris, it's excellent to be here. And I didn't even ask him to add that last bit, but yeah, it's been wonderful collaborating with you over many, many years in this space. And look, thanks everyone for the opportunity to be here today. Obviously, Chris has asked us to bring our different perspectives, and I'll focus, I guess, largely on what good collaboration and partnerships looks like in this context, and I guess from an industry perspective, and look forward to further discussion as part of the panel. We like to call this our welcome note from legal, but because I am referring to some Oracle product within the presentation, I just need to note that while those references do sort of, tend to depict general product direction, we obviously, things may change as we go along. So I guess I also wanted to note that while I am here as the vendor representative, it doesn't mean every view I express is through that lens. I too would like to acknowledge the traditional custodians. For me here in Sydney, it's the Gadigal people of the great Eora Nation, and pay my respects to elders past and present, and extend that acknowledgement to any Aboriginal and Torres Strait Islander peoples joining the webinar today. So I thought I'd just take a quick look as an introduction of who I am, but do that a little bit visually. Chris has already, I guess, identified most of my history, but I suppose first and foremost, I'm a registered nurse, still registered, but I've added a few other titles to that moniker. On my way to becoming a lead healthcare executive with Oracle, I guess I discovered my interest and fascination with all things digital health in critical care. And as you can see, I'm there in the RPA's server room in their intensive care service, living my best life among all the network spaghetti. And then, I guess, following program and policy roles at New South Wales Health and eHealth, I went on to become the Chief Clinical Information Officer at the Australian Digital Health Agency. I was also awarded a Churchill Fellowship through global research into digital health and patient safety governance. And that's something I have a really deep and abiding interest in. And I suppose, as Chris has mentioned, a couple of board roles, which are also highly relevant to the work that I do. And finally, adjunct roles with Sydney Uni and La Trobe. So as I mentioned, while I'm bringing, I guess, a vendor view today, it's also very much informed by all of that experience I've gained across my career. For those who don't know Oracle, very briefly, founded in 1977 by Larry Ellison, who may ring a few bells for some. We are a multinational tech company. I guess really database software, cloud, and cloud systems, enterprise software. And I guess we operate across just about every industry, so that be finance, retail, consumer, government, construction, engineering, manufacturing, and so on. But on the health front, Oracle acquired Cerner in 2022, and that brought health and life sciences into the frame. So while people, I guess, Cerner's sort of been synonymous with electronic medical records, we're using, I guess, the might and experience across all those other industries to bear to expand those capabilities in the health space. So today, what was previously, really largely focused around the EMR, it's gone on to push well outside of that context. So I guess in thinking about what good collaboration and partnerships can look like across industry, I just wanted to highlight a few examples here. From a research collaborations perspective, there are some good examples, in particular internationally, one of which is the Ellison Institute of Technology at Oxford. I think that was established around 2023, and that's been, I guess, really about improving commercialisation of scientific discoveries in the UK. And I know their focus is in a few different areas. There's health and medical science, food security, sustainable agriculture. I believe there's climate change, and also AI and robotics. And I think that there's a new campus opening in 2027 there. We also recently launched an AI Customer Excellence Centre to drive innovation across Australia and Oceania in Sydney. And I guess that's really about providing a regional hub to help organisations adopt the latest AI innovations and accelerate that business transformation. I guess locally, we've frequently contribute to grant applications, and we sort of provide that those contributions through expertise in governance as part of those applications. And again, we contribute to through adjunct roles in universities, providing that in-kind support for academics and students. And it wouldn't be a presentation without mentioning the National Spark program. And we're a partner of that with the CSIRO and other government agencies. And as you may or may not know this, the accelerator is about building a fire standard. And I think what really stands out for me as a differentiator for this piece of work is how public policy, well, as distinct from how public policy has been developed previously, this is just a completely new frontier, particularly how it's engaging the broader community in that collaboration. We also run an academy, Oracle Academy. I believe that's been running about 25 years, and that provides free curriculum, software and cloud resources to academic institutions worldwide, and you may be surprised to learn that. There also is an Oracle University, and I believe through their skills development initiative, they collaborate with, globally with governments and NGOs and other agencies to accelerate digital transformation initiatives. And that's through sort of joint investment in local tech and talent, and also with supporting job placements. And from a workforce development perspective, we do that through participation in industry-based learning programs. There was a local example there that Chris has referred through the IBL program. And I believe there's been some discussion there with our chief AI scientist, who's also based in Melbourne and was a former associate professor with Monash. So, like Chris said, these are really important programs of work, sort of building a pipeline and particularly for top talent. Other ways we collaborate across industries through thought leadership, and we have been collaborating with the AIDH, conducting industry roundtables, talking about health system transformation and what is needed to bring about real and sustained change. And if you scan that barcode, you'll see our most recent paper, which was published in August. And I say we, that being very much a collaboration led by the AIDH. And Chris, I believe that was something you were part of. And I think just one other particular example I wanted to highlight was a sort of a research translation in practice, and it's through the Learning Health Network, which got a sort of I guess a similar but adjacent concept to how we might all understand what a learning health network is. But this is a US example, and it comprises data from about 232 US-based health systems. And it's really about sort of fueling that innovation in life sciences and enhancing patient care as a consequence. So there are something like 71,000 hospital beds across nearly 4,500 facilities. And those are really diverse data sets, again, representing the US population, but bringing sort of, I guess, some confidence in how that's represented in trial results and efficacy. Lots of peer-reviewed publications across all of those different areas that are identified there on the screen. And I think over 200 active research projects. So we're in the early stages of exploration to bring this to the Australian market. So to that end, we'd be very interested in having discussions with people who might want to learn a little bit more about it. And I guess, look, I guess finally what I'd say, why this matters. Ultimately, we all want to have greater impact. Our holy grail is better patient outcomes and a more equitable, sustainable health system. And really to do this, we obviously need a better skilled workforce. Chris has already highlighted that, something we know is an enormous issue for the health sector, where we know that workforce is really unable to keep up with that rising demand. For research, we know it takes, 15 odd years to get evidence into practice, and there's even less volumes of that research as part of that translation. And I think on the topic of AI specifically, some may have heard Dr. Chris Longhurst at MedInfo in 2023, and he called out that researched algorithms are rarely implemented and implemented algorithms are rarely researched, which I think it's a bold statement, but I think there's, that it's based in evidence, but I think we'd all agree that's starting to change. I guess on that point, when I think about the work that we're doing locally, bringing new products to market here in Australia, we're starting to evolve that approach, proof of concept testing, sort of the utility and usefulness in local contexts. We're doing this particularly with our clinical AI agent, Ambient Note. So looking at that sort of very patent type methodology and research. So I think this sort of approach really requires intentional collaboration, and it's not just the purview of one entity alone. It's not just about investing money. There are lots of ways to contribute, as I guess I've tried to highlight. But I think we know that universities obviously play a really critical role in helping industry introduce that new technology, because often organisations will lack the sorts of resources and expertise that universities are really well placed to provide, like, developing, rigorous research and validation studies, but also helping us sort of trial and evolve the products, which is really critical to growing the evidence base. And similarly with with some of the labs that will be able to mimic clinical settings, again, that organisations might not typically have access to. And that also is part of that sort of testing in real world like environments before they're out into the wild. So I think those innovation hubs are really important as part of that. So I think in highlighting the sort of the how and the why, we should also be considering what the barriers are that might exist in that execution, and sponsorship and timelines spring to mind in addition to sort of regulation and of course the many competing priorities and demands. So I'm really looking forward to unpacking that a little bit further through our discussion. And to that end, Chris, I'll stop sharing.
Wonderful. Thank you very much, Angela. I think Chris Longhurst's comment is still very true. Very, very true.
Yeah.
If anything, the shift towards we need to sort of assess in the real world even more is the weighting is even more that way at the minute.
Yes,
I will now.
agree.
Sorry, Angela.
You go. No, sorry.
I was just going to say I'm going to introduce now. I'll give him a heads up for him to share his slides. Associate Professor Ashwin Subramaniam. Ashwin is somebody I met in Prato last year at the ANZIC's Core event, where I was lucky enough to speak briefly about AI. If you can start to share your slides from your end, Ashwin, that would be great. Ashwin, apart from being involved in ANZICS, he completed his postgraduate training in ICU medicine in 2013. He holds a public appointment at Dandenong Hospital, which is part of Monash Health, which is arguably the biggest health service in Australia. He's a senior consultant there and also the ICU research lead. He also works at Epworth Hospital, has previously worked at Peninsula Health as a senior ICU consultant. He was also the director of ICU at the Bays Private Hospital up till 2024. He's a fellow of the Royal Australasian College of Physicians as well and works as a perioperative physician in Dandenong Hospital. So with that, I'll hand over to you, Ashwin, and I'm looking forward to hearing what you've got to say.
Trying to figure my mouse. Sorry, apologies on that. I'll share my screen again. I hope you guys can see my screen. Thank you so much.
We can, in full screen.
Fantastic. Thank you. Thanks, Chris, for the introduction. And thank you for inviting me to be part of this fantastic discussion today. I'm going to take a different slant to what Angela said, and Angela's talk was amazing and really, really inspiring. I wanted to talk about translating digital health in R&D from an ICU point of view, and I'm going to talk more about what works, what doesn't work, and see how we go from there on. So as Chris had mentioned, I am an intensive care specialist and I work in Monash Health, and I sort of run the ICU research program in Dandenong Hospital. And I've also worked in Epworth Hospital, where I sit as in the committee of the clinical deterioration across the entire Epworth network. So what I wanted to talk about is how do we explore a simple idea in digital health? Our biggest problem isn't just a lack of innovation, but it is lack of translation into real world practice. So before I begin, I do not have any conflict of interest to declare. So before I jump into digital health, it's worth pausing and thinking about the environment this actually needs to work in. The ICU is a very high pressure and a time critical space, as we all know, and the decisions are often made quickly with incomplete information, and there is very little room for error. At any given time, you're looking at multiple patients, responding to alarms, coordinating with team, and talking to families. And sometimes many of these happen at the same time. So there's really no tolerance for inefficiency. So if a tool slows you down, even slightly, it may not be used in real world. So that's why I often say, if it doesn't work in ICU, it may not even work anywhere. So with that perspective, I'm bringing today is very much a practical one, not just what we build, but what will actually work at the bedside. So a lot of what I do focuses on frailty and decision making. By the way, I did do a PhD in frailty, and probably I'm one of the highest published intensive care frailty researchers in Australia and New Zealand, and probably even the world. I've got more than 100 publications just on that. And I also look into how we can improve goals of care conversations and make sure it is a standardized framework to it. And I also like to understand the deterioration and escalation of patients, particularly around ICU admissions. And what I also am working towards is see how we can improve patients, especially with frailty, to become stronger so that they can undergo complex surgeries. But when they are in the last leg of the race, I also want to define some controversial concept called as a time-limited ICU trials for these vulnerable patients and try and define when these care changes and pathways need to change to more comfort measures. So with that, I wanted to talk to you more about this one. If I had to summarize the challenge in one line, it would be like this. We don't have a shortage in innovation in digital health. We have a translational problem. And I think Angela also mentioned that briefly. We are very good at generating ideas, building models, and publishing results, but we are much less good at taking those ideas and making them work in the real world. And that gap between what we develop and what actually gets used is what I want to focus on today. And this is, by definition, called as a translation gap. We have strong research, validated models, and sophisticated analytics. But at the bedside, they're not often used. And sometimes, if we're honest, they become what I call as PDF innovations. That is, the paper may look great in a PDF form, but never make it into real practice. I have done a lot of research using ANSICS registry-based datasets, and I actually have full access to the dataset. And I'm just giving you one example here where I had written a paper recently that was published in Critical Care Medicine, one of the higher impact journals, that talked about frailty and identifying acute hypoxic respiratory failure and mortality. As the colorful graph shows, you can see a clear separation between frailty and increased probability of in-hospital mortality. CFS is clinical frailty scale. 1 is no frailty and 8 is really, really frail. And you can see that there is a clear demarcation with every increase in frailty resulting in increased mortality. And what is also quite interesting is the PF ratio. The higher the PF ratio, the better the mortality outcomes are. And you can see that when it hits around the 200 or 220 mark, you can see an exponentially increasing numbers. So what I've shown is the data is solid and the signal is fantastic and clear. But none of this actually tells a clinician what they have to do in that very moment when they're looking after patients. Because these decisions aren't made by regression coefficients or even spline curves, as I've shown here. They are made with clarity, speed, and context. So there is a gap between what we know and what we actually do. And that's where some of the good ideas may fail. And to understand why translation is so hard, you have to understand how decisions actually happen in ICU. And as I mentioned earlier, ICU is usually fast-paced and often very chaotic. And at any given moment, you're juggling with competing priorities. So the cognitive load is already extremely high. Any tool that is introduced has to work within that reality. Because if it adds even a small amount of problem or friction, it may not be used and it may not be incorporated. And there are 3 main reasons why things break when we try to translate digital health into practice. The first is a clinical misalignment. The models often build based on what's technically possible rather than what we as clinicians actually need in that moment. And the second is workflow disruption. If a tool sits outside existing systems or interrupts how people work, it just would not be used, and no matter how good it is. And finally, there is a lack of trust. If clinicians do not need to understand what the system is telling you or telling us and why, if, if that's not clear, especially in high stake situation, we won't be depending on that. So even if you have a well-designed model, if it doesn't fit into that moment, it will not be used, as I mentioned earlier. And that's why really where translation either succeeds or fails. And from my experience, there are a few things industries consistently look for. First, clinical relevance. So we need to ask a few questions such as, does this tool actually solve a problem and that clinicians recognize? Or not just that what can it be built, but will it actually change the practice for a patient that I'm looking after? And second is workflow integration, how it fits into how we deliver care. And if it adds steps or slows down things, it may not be used. And finally, scalability. And last but not least, how is it, whether it is implementation ready or not? And what's the pathway to real world use? Who owns it? And how can this all get integrated? All of this is extremely important, and this needs to be taken into consideration. And what actually works, and these are some of the solutions that I thought are important. And many of this has happened over, and I have also been involved in some of them in the EMR with Cerner in Peninsula Health when I was working there, is if it is co-designed with clinicians from the get-go, if the platform or the tool is simple or intuitive, and it is embedded in the workflow, and it is aligned on how decisions are made. One example that I am currently working on is creating ICU dashboards. And I did hear Chris talk about dashboards. So I am interested, Chris, from Monash Health point of view. So using early data to generate real-time insights like mortality risk, likelihood of a patient needing mechanical ventilation or renal replacement therapy. From an ANSIX point of view and Apache and all of that, we know that within the first 24 hours, the mortality can be X, the likelihood of mechanical ventilation could be Y and whatnot. But it is not transferred into real practice. And so what I want to do is to see if I can incorporate that into day-to-day practice. And not only just with the first day, but rolling on like day 2, day 3, and day 4, and see how this information is presented and where it appears. All of that will, I believe, will change the way we look after patients. Excuse me. And so if that's what works, the obvious question then becomes, how do we design research that actually gets there? I think the starting point is very simple. We start off with a simple clinical question and not the technology. Because if you start with the technology, you'll almost always find a problem for it, not just necessarily the one that the clinicians recognize. And the second one is we need to design it for the end user. And from an ICU clinician point of view, we really need it. It needs to be clear, the speed of use, and trust. We don't really rely on complexity. And finally, we need to think about, it has to be beyond efficacy, to be honest. We are very good at asking, does this product work? But the more important question is, will this be used? Which means thinking about workflow integration, feasibility, acceptability, and cost right from the get-go and not as an afterthought. And finally, we need to plan for scale up very early. This is one of the works that I'm currently doing, and I'm just going to share a 45-second video if you don't mind.
I'm not sure if we've got the audio coming
Yeah.
through, Ashwin.
Oh, I'm sorry.
Yeah, no
Apologies.
sound.
Can you, sorry, can you hear it now?
No, no.
Okay. Okay. Apologies. Oh, I thought it would work. Apologies. So what I've actually shown is a clinical avatar that we created using AI and with the collaboration with Professor Charlie Koch, who used to be the college president and has done a lot of work in communication with patients. And as I mentioned earlier, talking about goals of care has always been my passion. And so what we did was to create a tool that could be used to train junior doctors. Junior doctors historically have not been really good with communication with patients, especially when it comes to complex decisions. So what we did was try and test it out with them, and we did a pilot study recently, and it's actually been submitted to a conference as we speak, and we've also written up for a grant application for scalability point of view. And what we noticed was just with 3 or 4 iterations of junior doctors communicating with this avatar, they were able to actually identify where the problem is and they were able to improve on. And more importantly, what they found was it was excellent from a psychological point of view, and they called it a psychologically safe environment and not being judged upon. So that was a really, really important feedback for us, to be honest. And I think with these sort of models, if we can show that it is scalable and make a difference, I think this will definitely work. And another good way to understand this gap between innovation and implementation is something we're working on in our own ICU. And I've called this project as a VR Care ICU study. And this is a study that we have just started in Epworth in cardiac surgical patients, where we have designed VR content that is based on a diorama of Alice in Wonderland sort of a theme within quotes, where the girl goes and does some adventure in the attic and finds different, equipment and plays with that, and each becomes a journey and a story on its own right. So it was a fantastic point of project, and the research perspective is really, really strong. The VR content is well designed, and concept all made sense on paper. And we were confident that the patients will benefit from this. But academically, it works. But as a clinician, the reality looks quite different when we are looking from a bedside point of view. The questions that commonly come up were how safe can we clean this equipment, and how easy is it to use it in ICU environment, and who actually sets it up, and when, and is in an already busy ICU workflow, and can we use it in fatigued patients or patients who are delirious, and et cetera, et cetera, et cetera. There are so many questions, and we actually published a paper just to show what are the barriers and facilitators of doing such a research. So I feel that they are not mainly a technology problem, but they are real world ICU problems. And that's really the gap we're talking about. The university, I mean, this girl is from Deakin, and they bring the innovation here. But in our ICU, we just have to make it work. And that's the second part. Making it work in the real world is where most of the effort actually is. And this is my second last slide. We need our clinicians who understand data, systems, and implementation. So what we have done in Dandenong ICU in collaboration with Chris, we have starting a new pathway called as an ICU AI Transitional Fellow. So a transitional fellow is a clinician who has passed his or her exams, and are waiting to become a consultant. So they have to go through the rigors of being a consultant before they graduate. So what we thought of is introducing an AI sort of understanding, and see if they are able to bridge the gap and translate models into real decisions. I hope this works, and if it does, it is definitely scalable. And there's already interest in other health institutions. So finally, to bring it all together, in critical care, and really across digital health, we made enormous progress. We now have data that gives us insight, models that generate signals, and tools that create real opportunity. But none of that translates into impact unless it fits into how care is actually delivered. That means aligning with workflows, reducing cognitive load, and supporting decisions in real time, because ultimately that's what matters. So the question I always come back to is, will this change what I do in bedside? If the answer is yes, then we have an impact. But if it doesn't, the innovation will become not translatable. So thank you so much. And one last thing is, we are organizing this conference in September, and I am the adult convener. So I would love to invite you all to attend this conference. Thank you so much for your time.
Thank you very much, Ashwin. Lots of really good stuff there. I've written down a few questions to come back to. We will absolutely make the translational AI fellow work. Not a question of whether it will work or not. It's all good. And just for people's general interest, some other ICUs have expressed a bit of interest in that model too. So that's great. With that, I will hand over to our next speaker, and I'll ask him to start to share his slides, and that is Dr. Tim Fazio. So Tim is a fellow of the Royal Australian College of Physicians, a fellow of the Australasian Institute of Digital Health, and a certified health informatician Australasia at CHIA. He's a recognised thought leader in clinical informatics and has utilised IT innovations to streamline hospital processes, improve patient safety, reduce hospital costs, and improve clinician satisfaction. And Tim is currently employed at Royal Melbourne Hospital as a Chief Medical Information Officer and Head of the Metabolic Diseases Unit. So he's in a very niche area and highly specialised area of medicine, as well as his interest in digital health. So over to you, Tim.
Thanks, Chris, and thank you for the invitation to join the panel today. It's shaping up to be a great chat, and I look forward to the Q&A coming. I haven't got any slides. I thought I would just talk rather than present some pictures. But as you mentioned, a bit about myself. I work both clinically and in informatics, and have done for quite some time at the Royal Melbourne Hospital, being the inaugural informatics registrar back in the day, and moving up the ranks. I'm part of the team that went live with Epic EMR across the Parkfield precinct, and we're very lucky to have that in place where we are at the moment, sharing a fully digital EMR with the Children of the Women's and Peter Mac. And because of that, we have a fair amount of data and a fair amount of potential to change workflows and digitally transform the way we look after care. And both the data and the research side and the transformation care side are part of my informatics role. It's a busy space though, and it's getting busier and busier. I think a long time ago, we used to just think of digital health as putting in an EMR. And now I think we're thinking well beyond that. Where is AI? Where are scribes? What's governance? What's process automation? What's the software you can bring yourself? What's the governance around all of this? How do we understand whether an AI model that works in the US will work in Australia? How do we understand all those kind of things? And more, it's becoming a bit of a mouthful, a bit of a handful to sort out. And I think today's talk is really about where we can partner in terms of R&D and with universities and things. And I think it's tricky because we have a lot of clinician scientists. We have a lot of people with PhDs and professors and all sorts of things within the hospital. And why we need to go to the university and where that's advantageous to us and where it's not is a really interesting question and worth fleshing out a little bit. And equally for me, which university to go to. We've been called academically promiscuous by some in the past, and whether we should stay that way or not is an active question. So, look, in terms of the crux of my talk, Andrew actually foreshadowed it. I was going to say the exact same thing, that 99% of models that are researched have never been implemented, and 99% of things that have been implemented have never been researched. And taking that paradigm and extrapolating beyond just models, but kind of digital informatics tools, I think it's probably fair to say that a lot of what we use today and the way we use it and the way we've configured it is not necessarily something that's ever been studied or researched. And how we assure ourselves that what we're doing is actually best practice, how we try not to reinvent the wheel, how we try to learn from others, and how we make sure what we're doing is what's right. It's a tricky question. My honest experience with research partnerships have been a bit hit and miss. I think there's projects that we can all think of here where we've partnered with somebody and done an evaluation. We've ended up really evaluating whether a framework was suitable to use in the evaluation process of an evaluation, and haven't really actually answered our question, did we turn on something that was good or did we make a difference? And it was a very kind of academic meta kind of lens. At the other end, we've had these really fruitful collaborations where we've co-designed things and we've workshopped stuff together, and we've got research output, we've got papers, we've got grants, we've really understood where we're going. And the difference between the ones that work and the ones that don't is really about a shared understanding and a true partnership in terms of understanding what our needs are. And often it's more operational than purely academic or research at a kind of pure level. And also the timelines are generally very, very different. There's no time to put in a grant, wait 3 months to hear, wait 6 months to get the funding, start a project, do the project for 3 years, wait 2 years to publish, and 6 years later you've done something. The hospital's generally got some money, needs to be spent this financial year, hoping to have an ROI or an evaluation done within 12 months. And how those two paradigms align and funding mechanisms is quite a tricky thing to sort out. I think that pace mismatch is structural, and I think it's probably one of the main reasons that 99% implemented and researched barrier exists. The gaps that I feel most acutely, I think, is probably more on the researching what we've got rather than implementing what's researched. But I think both are true. I think we make significant investments in digital tools. We deploy, huge scale EMRs or tech pieces, or spend tens of thousands, hundreds of thousands, millions on tools that we perhaps don't know whether we're doing things as well as we could. And so how we moved from a paradigm to just putting a business case forward to implement, to making sure there's always an extra 5%, 10% to do a rigorous evaluation, understand where it's working, I think is something that we could learn from the hospital side. But how to make that a bit more efficient and easy and streamlined from the academic side, and how it's kind of almost a fait accompli that we will do a partnership and evaluation, is something that I think could be interesting to explore. I think the methodological rigor and the vendor independence at universities helps answer that kind of question in a way that partnering with an actual vendor might not, or having people who are project managers but not academics do an evaluation, you get a slightly different angle. And I think having an evaluation kind of bolted on or after the event, post hoc analysis, is probably not the way to plan things from a project management perspective. I think helping us make better choices faster would be a useful thing for us to do. If we're genuinely faced with, should I turn on this dashboard, and let's get our BI team to spend 6 months building it and working with it and things, could we just ask somebody who can do a quick lit review or is doing a PhD in the space or understands the area, say, yep, don't waste your time with that. It's never been shown to do anything. Focus on this, and let me connect you with these 3 people who've done this already. And in fact, we can probably share the code because it's all open source. How we actually learn from each other and share that academic learnings in a way that is, to Ashwin's point of view, implementable and usable in front of us today and actually gets translated, is tricky. And I think we haven't got that right at the moment. In terms of education, I think Angela mentioned how we come out of university digitally enabled, but I think you've got to remember that we've got 12,000 odd staff at Royal Melbourne who've already come out of university, and how we keep them up to speed with the latest information, how we have ongoing education, how we make sure people are digitally literate, AI literate. Do we know where our staff are? And I think the way a lot of traditional university teachings are structured is a bit too deep and a bit too thorough for a lot of what our day-to-day staff need. So there'll be some people who really want to do a master's degree or do a PhD in digital and make a career for themselves, but the other 12,000 people that need to use our systems and need to know where it's safe and need to know what the gotchas are and need to be able to speak IT to get a little bit of digital transformation done in their area, what's the right pitch for them? And they're clearly not going to want to become academics, and we don't need them to necessarily be able to become academics, but they need to have some more skills. And so whether that's short courses, whether that's embedded education, whether that's in-services, whether that's different ways to do education, I think there's some opportunities there. And I think the kind of traditional model really only suits quite a few, the kind of tip of the iceberg of need rather than the foundational need. And speaking about education, I think the students at the university have a lot of time and a lot of interest and a lot of passion, and hospitals need people to do stuff. But the ability for us to use students and to accept students is tricky when it comes down to ethics, when it comes down to project timelines, when it comes down to budgets, when it comes down to kind of the university life cycle. You need to try and squish a project into a single semester or into 2 semesters of work. It can become really tricky to find something that lines up with what the hospital's doing at the time. If I think about medical students coming to work at the Royal Melbourne Hospital, there are kind of overarching collaboration agreements. We don't need to get them, made an honorary and check their measles, mumps, rubella statuses and all those kinds of things that often hinders getting a IT student on as an honorary. And there's kind of data sharing agreements that can just be used in ethics applications without reinventing contracts and things. And I think how we do that from a IT student perspective, informatics students, data students, translational science students, information science students, how we do that at a higher level to make it easy for both sides to get what they need out of that relationship is something that I don't think we've got right yet. In terms of what good looks like, I think embedded research partnerships are good. I think research is in the room when decisions are being made, not arriving after the fact. I think trying to find shared areas of interest and bigger pieces of work that perhaps do fit into that grant cycle and can be chunked up and kind of gradually progressed and morphed as time goes by. I think designing for a hospital operational pace and crisis pace often is something that we could do better at. And I think investing in people who can translate between both worlds, your translational fellow opportunities is exactly that. It's somebody who tries to do the clinical and the informatics at the same time without necessarily just sitting in just one camp. I think there's huge untapped potential resource here, and I think if we can realise that the potential is enormous, I think it'd be great if we can get this better. I think both sides of the academic and industry, as Chris calls me, the hospital side will work better. And I think if we can stop operating in parallel universes and be a bit more collaborative in what we do, would be great. I think if we can bridge that gap of researching what's implemented and implementing what's researched together, it would be a much better spot for us to work and to receive care. And interested to hear where this chat goes, Chris.
Thank you very much, Tim. You promised to be contentious. I didn't feel that was too contentious. It raised a lot of very good points. It's good, all good stuff. We'll come back to some of that. And points about the differences between the health students who've been embedded in hospitals for generations versus non-health students, a very real issue, as you've said. I think we can do it collectively a lot better. I'm going to hand over now to our final speaker and ask Suma to share her slides just while I do an introduction for her. So Suma Shibalingaya is somebody also I've met recently. In fact, I think we met 12 months ago at the Digital Health Festival, Suma.
That's right.
Excellent. And since then, I've had a lot to do with Suma. We're interacting on quite a few things, which has been wonderful. Suma is a results-driven, successful senior IT leader with 20 plus years of experience gained across government, utilities, education, financial, and the medical and health industry. And she's currently the CIO and immediately currently acting executive director at Eastern Health. She's a well-regarded professional within the IT industry, having established a reputation in building trusted relationships between technology teams and businesses. And I must say, I've been working sometimes directly alongside as a peer, but with CIOs for an awfully long time now. And I must commend Suma because she has a mindset around the ability to be innovative and interact with unis and other things in a way that potentially I haven't seen much before. So I will just say that in introducing Suma. But over to you, please, Suma.
Thank you, Chris. Thanks for this opportunity. Just wanted to introduce myself. As Chris mentioned, I'm the CIO at Eastern Health. I've been the CIO for the last 3 years and at Eastern Health the last 5 years. I'm also the nominated chair for the VIX Health CIO Forum, which is a group of all the CIOs across the state, and the board member of Banksia Palliative Care as well. Before we kick off, I just wanted to give a quick intro of what Eastern Health is and who we are. We're one of the largest public health services. We have multiple locations in where we provide care, 60 plus locations, as you can see. Our promise is healthier together, healthier for our staff and healthier for our consumers as well and patients. We provide a range of services, emergency, surgical. We have a statewide drug and alcohol program. And we also provide many other services there. Just another glimpse of the wonderful work that is done by staff at Eastern Health. So we have around 13,000 staff. We have 3 ICUs. We probably more than 1.4 million care episodes have happened. And we have 200 plus business applications as well that we support. Why is this important for us? Well, while we have quite a large population to support and quite a lot staff to support, still we have challenges. And I think, like all my colleagues here mentioned about the challenges we face, to provide better care, we do need the efficient systems to perform the way they're supposed to perform. And some of the challenges that we face in the healthcare sector is the ever-growing cybersecurity threat landscape, which also with AI has, and the geopolitical conflict that we have has increased. We constantly have challenges with retention of talent and upskilling resources. And this is where we look at partnerships. And thanks to Chris for driving the digital health partnership with Monash. That has been a fantastic program that we're running. Also, the ever-growing budget challenges that we have, and now so more with the supply chain issues as well. We have a growing technical debt. And as we try to catch up, it increases year by year, and I think probably Tim and Ashwin might agree to that in terms of how we modernize systems, but we still have a growing technical debt that we have to cater for. Also in the enterprise architecture space, there's a lot of improvements that we have introduced, but it is also a challenge in terms of improving and stabilizing that area. And in the data space as well. So I also manage the data team, the data analytics team, and the data science team as well. There's quite a lot of challenges in the skilling aspect of that in that space as well. So our digital health strategic roadmap has been developed with for the next 3 years. We've just completed the last 3 years and successfully delivered quite a lot of programs in this space. The next 3 years has been defined underpinning 5 strategic objectives. The first one being reliable digital and data foundations, cloud migration and modernizing our fleet. The second one is around secure and resilient digital health platforms around the cybersecurity space. The third one is around the connected and insight-driven care that we need to provide and use data, which is available with around 200 plus applications that we run in how do we make better decisions utilizing that, and also providing the data in the right time, the right platforms as well. The fourth one being the digitally confident workforce is how do we actually train our workforce in using the technology tools that we have and we promoting as well. We have multiple literacy programs running, the AI literacy program, which is running from last year, which is really successful in empowering staff in using AI in more of a governed way and also in bringing out the innovation aspect as well, which leads into the final objective we have, which is innovation and AI that improves care and productivity as well. So these are a couple of our strategic objectives that we have in our strategic roadmap in the digital health space. And the next question is around how can we improve on the partnership between universities. Some of the challenges that we see in this space is around the pilot project limitations. So sometimes we have great research projects that we have, but there is no pathway in terms of implementing that pilot and making it a reality or scaling it up and productionizing that in our health service. The other one is around the skills and environmental mismatch. So some of the skills that we require probably are not often there within the universities, and I think that alignment would be really appreciated. And I think there's a lot of improvement happening in that space as well. With the data access and governance, we have certain policies that we've been given from the Victorian Department of Health, which we need to follow in that space. And that's where we see that some of those aspects needs to also be embedded within the digital health platforms in the universities. And lastly, around the evaluation focus rather than the outcome focus, and then that's where we sort of see some improvements that we can align with the universities. I do have some recommended opportunities here. One is around the workforce capability, and I think this is a program that's very well run with Monash, where we see that we can embed some of the students within our sector and then train them in what we need, and we co-design that together. The next one is around the collaboration or the problem-focused partnership that we actually can co-design roadmaps together. So I think we should have more workshops within health services and universities so that we can co-design this research framework together. Understanding the pain points of the health services and understanding where the gaps are, I think that would be a really good partnership that we see together, solving quite a lot of issues in that space. And also implementation-ready solutions that we can support with our funding and support university students in research as well in that area. The key challenge we have is in some of the security and governance aspects is if there are certain controls that we follow in terms of open source products that we are allowed to use and we're not allowed to use, and how we can actually incorporate that in the research that we conduct, rather than using tools which cannot be scaled and implemented in the health service areas. And lastly, around the pathway to scale and sustain these type of projects, I think that is important, along with the funding that we need. Probably there is a model that we can look at collectively and pitch that together with health services and with the research partnerships on how we can fund projects together and projects that are helping us in this new AI innovative world, which can solve quite a lot of clinical problems that we see day to day. And there's a lot of problems. It's not like one or two problems that we have to solve. And I think Ashwin, Angela, and Tim will agree that there's amazing amount of work that we can do in terms of automation and AI in this space. I think there's a starting point. And I see this partnership is not anymore like an option. It is actually fundamental for our health transformation moving forward. So that's just a glimpse of what, from a health service perspective, what we need. But I'm happy to take questions. Chris, over to you.
Thank you very much, Suma. Would it be fair to summarise the theme of a lot of what you're saying there is about deeper, more structured, more planned relationships with universities rather than things that are so ad hoc and time limited? Is that a fair summary?
Absolutely, yeah. That's the summary, and that would match our skill set and match our needs and demand, and take us forward together with the great collaboration. Yeah.
Yeah, I mean, I certainly, represent that view internally to our researchers, saying to our researchers, the worst thing you can do is see a grant announced, the deadline's in 2 months, come to me and say, who can I partner with in the health system? I say, well, that's, one way to do it. It's not the best way to do it. The best way to do it is to have the relationships built beforehand, know the people and their problems, and then, having hopefully started some work, or at least knowing the people before you turn around and go, can we partner on a grant? But I appreciate too, there's much more to what you've just described than grants. Look, what we'll do is we'll cut to our break. We've planned for a 5-minute break here. If you just all bear with me a second, I'm just going to put the appropriate slide up. As long as the system at my end behaves itself, just bear with me. Things are getting a little bit laggy on my computer. I apologise. That's right. I'll figure that out once everybody starts their break. So if I can ask everybody to come back in 5 minutes, this gives all our speakers a chance to grab a glass of water, same for our attendees, a coffee or whatever it may be, and we'll resume our conversation with a panel and then more open questions to the audience in 5 minutes time, please. Thank you. There we are, Tim, because I was going to ask you first. I'm glad to see you. So I think how we'll do this, folks, is I'll direct a question to one particular panel member and have them answer. But then, of course, please feel free to chime in if you'd like to add something. And then part of the way through to the end of the session, we'll switch over to audience questions. So for the audience, please ensure you've got your questions ready to go in the Q&A box. We have a team keeping an eye on those. Just some quick scene setting. So I know from our university and our faculty, but I don't think we're alone. I think we're just an exemplar. There's an increasing push to focus on impact, not just because impact is a good thing to have, but I think impact's important to the future success of universities. One of the challenges, and I can say this now having sat for a decent amount of time in the health industry and in the university, is how do you incentivize impact and in that sense of having a real world benefit? So how do you change the systems of universities and academia such that it's no longer good enough to have a lot of published papers about models, as we've sort of heard, or a lot of citations or a lot of grant money or combinations, but how are you showing that you've made a positive change in the world? So, Tim, you mentioned something about different approaches you've experienced from different academics. How much of that do you think it's a personal mindset thing, or is it a university by university thing, or is it a different groups of researchers? Are you able to comment on that at all?
I guess I can only comment on those I've been exposed to, so I'm not sure how much of what I've heard is a university versus an individual versus their faculty or their group. But certainly there are different approaches from different people. I mean, people are all different, have different personalities and different philosophies. I think some probably have access to more discretionary funding, or know about a opportunity where they've submitted to a digital CRC or something and need to spend it, and they can partner and do something, as opposed to coming without money and saying, hey, let's go on this grant, or could you just pay us to do this work for you, which always goes down well in the public hospital. So I think there are different approaches. I don't know how much of that's an individual thing or a university thing. I think my kind of local experience from a clinical school partnership is it's very school specific, which makes it very tricky with digital. Because if you're in ICU and wanting to do an ICU thing, you might go through the Department of Critical Care, and they've got their statisticians and implementation people and their professors they like to work with, which is very different from going through a faculty of IT or engineering, computer science, health transformation kind of school. I think the schools are quite separate. And certainly in health, there's a school of crit care, but there's a school of medicine, there's a school of ID, there's a school of, and they've all got their own little silos. And then when you try and get approached by one of them with a grant to do digital, or Tim, hey, can we turn on this? Can we do this AI? Can we do that predictive model? Can we do that? Then how do you kind of link their school back with the IT, implementation science, model understanders? And so I think there's probably a part across the uni where digital health needs to become more embedded with the relevant clinical components. But I do think there are different approaches from what I've seen. I think the partnership approach, where you genuinely have kind of people embedded with each other, is there in the clinical stuff. I don't think it's there in the non-clinical. So I think if you said we've got a genuine clinician scientist who spends half the time at WeHi and half the time at Royal Melbourne seeing patients, and they're doing immunology, so yep, that kind of works. Or I'm genuinely the professor of the School of Crit Care or whatever, but I also see some patients and anaesthetize some people, and I think that works. I'm genuinely a executive at the hospital and the professor of IT. Now that's obviously we've got one of those just started, but that's a first for us, and I think that kind of trajectory is probably where we need to go.
Yeah, and that's going to be very interesting to see how Peter. So there's a new role for the audience, a new role at Royal Melbourne Hospital, which is Chief of Transformation, but the person doing that is also a professor in charge of Academic Centre in Digital Health. So it's going to be very interesting and hopeful that that's very successful as well. Did any of the other speakers, Angela, did you have a comment on that question?
Yeah, I guess I would say, I mean, I think Tim's right. I suppose in my experience, it has been, and I suppose to your original question, it's very people focused because that sort of brings the trust and sponsorship.
Yeah.
And in some respects, it's also inherently political. So that those are really sort of tightly coupled. And if we think about, I mean, some of what Tim's also described is sort of a microcosm of the sort of broader health system. If you think about all of the different competing priorities, just even if we think about the way technology's been enabled through health services, very organic, it's all at really different sort of levels of maturity. And I think if we could, start all over again, we do things really differently, but we're sort of, this is where we are. I think the best sort of intentions don't always sort of lead to that impact. And, if I speak about I've learned a lot about sort of the vendor world, I suppose, in the couple of years I've been with Oracle. And again, that's, there are really different drivers and priorities, if I can say that, for the way the sort of vendor business runs. And it's not necessarily as straightforward as just being able to find funds to sort of support research. And while we might, myself and plenty of my clinical colleagues within the organisation and even the leadership agree that all of the products that we build should be based in evidence and should be part of research. But, there's kind of a whole piece that happens before it ever gets out into the real world, and there's been significant investment. And so I think if we could potentially think about how we might inject into that pipeline a little sooner, that would be a start. But at the same time, I think Suma did a really great job too, and everyone mentioned it, but just thinking around the governance, governance in health services too can be really complex. So if those structures don't exist, then, the enablement can be a little bit further challenged. So I think, generally speaking, I do think it is, it's really largely based around who's part of that leadership and where they see that value, and whether they've got the ability to sort of influence that.
Thank you, Angela. I mean, I certainly agree. From again sitting on both sides of this for a long time, the interpersonal relationships are the crux of it, and you hope to then get traction in both organisations based on that person-to-person interface. It can be a challenge. Ashwin, I'm going to go to you, but I expect Suma you'll probably have some comments on this too. But Ashwin, you made a point about tools and innovations coming in that needed to be implementation ready. And you mentioned this idea, for instance, of who's going to own it internally was one dimension of that. Can you talk through the other dimensions you see of implementation ready from where you sit?
Sure. I mean, no problem at all. That's a fantastic question, to be honest. From an implementation point of view, I was just talking more in terms of the clinical avatar that I talked about. It was a fantastic software. The way we had designed it, I mean, I had designed it from the get-go along with Charlie Koch and a couple of our registrars who had shown fantastic insight and enthusiasm. So we started off in a very, very simple tool, and the avatar actually has come up in a fantastic way. What was initially designed, it all came about during the COVID times when there weren't any face-to-face interactions at all. And, we were all part of running the communication courses. And that's when this idea all stemmed. And then what we wanted to do was, as part of our ICU fellowship examination, communication is a key aspect of it. So therefore, and all candidates are in some way, linked to breaking bad news, goals of care, and all of that. So that was the idea behind such a thing. And it took us almost like 4 to 5 years to get it where we are at this point in time. And what we have designed is multiple avatars that is culturally sensitive and, ready to go from different aspects. And we've also trained it at different levels of complexity, from being very simple to very, very complex and challenging a clinician to, in a way. And so what we've done is this one is ready to go. and we are able to implement it right away. And that is what I was trying to say about the implementation readiness. When it comes to other things like ICU dashboards and whatnot, I've got some vision and idea, and that's still conversations happening with Monash University. And as I said, the bigger problem was with data security and sharing and how it all comes together. So therefore, there is still a work in progress, and I don't think it is ready from an implementation point of view from that aspect. But from the goals of care point of view, I think it is ready to go, and we should be able to showcase it. And we are planning on a big multicentric study. And the other beautiful thing about the goals of care project that we did was we validated the avatar. What it actually does is it talks to you, and then at the end of it gives you a summary to say what you've done well and what you haven't. So, and we tested it out and matched it with exam candidates and also with the examiners, and it actually matched out fantastically well. So we know that it is a validated product ready to use, and it could scale up anytime and everywhere.
So I guess what I'm hearing there, in essence, Ashwin, is the outcome of the product development process is highly aligned to your original vision because it was designed with clinicians from the start. And also, sometimes we push products into a next level, like into a production environment that still don't have a compelling suite of functionality. Whereas sounds like you've got all the functionality you want before it's gone live. There are different ways to do that, but that's a helpful answer. Thank you. Seema, from your point of view, what does implementation ready look like? And do you agree that when it comes to some of these R&D things, they don't turn up implementation ready?
Yeah, I think from our perspective, implementation ready is having that buy-in from the clinicians and the technology staff from the beginning. And also setting up the platform so we are collaboratively working on tools and techniques and the architecture from the beginning together. Because then that gives us ample opportunity to just scale it up and then make it something tangible. And you said positive change in the world. I think that is where we can bring that faster positive change by having this great R&D and research done, and then implementing it in a timely manner. Because often we find that we're doing things with legacy platforms, and we're doing things which is not modern enough that we can actually support, and helps us with our reducing our technical debt. So I think that is where we see a partnership where we can actually develop it from the beginning with the buy-in of the clinicians, understanding the main pain points for health services as well. Because I think, like you said, Chris, sometimes research is done that we've got a grant, we've got a problem, we're trying to solve it. But is that problem actually a real problem for the health service is something that we're probably not revalidating. So if the roadmap is defined at that level, then all the R&D work will have a platform that we can actually scale and make a positive impact.
Thank you, Seema. I mean, this is, some of these issues are very well exemplified in that telehealth project I mentioned that hasn't used the sexiest technology, but it's used technology that was acceptable to the vendor partner and an approach acceptable to the vendor partner and the broader funders. And that's enabled it to get traction and move forward, even though if you ask the key researcher, she would probably at the time disappointed about the technological constraints, if you like. But ironically, that trade-off, which she herself acknowledged, has enabled that to be more successful and go further. So I think there's a tension there, especially for technology researchers and engineer researchers, to say, well, this mightn't be the sexiest thing I want to do, but I can see that if I approach it this way, it maximises its chance of uptake and impact and all the positive trusted relationships that come from that. And then you can have a conversation about the whiz-bang grant for the next thing because you've done something valuable for them. That's why I was a bit asking Tim about mindset before. I certainly can see that amongst my colleagues in the sector. Angela, I'm going to ask you a bit more, and I'm sorry if I'm putting you on the spot, a bit more about the Oracle Health and Life Sciences Learning Network. That seems very interesting. And you mentioned maybe trying to bring that to Australia. I'd be certainly interested in conversations about that. Can you tell us about what's motivated Oracle Health to do that, and what are they seeing from that? I appreciate you're not intimate with it, but are you able to address that?
And look, one of the reasons I put it out there, Chris, was I thought it might pique your interest straight there. So I'm glad it achieved that that outcome. Look, again, it's a fairly new concept internally for us here in Australia, because its widest use, as I presented, is in the US. And I guess probably the key driver there is access to real world data. So it's, obviously there's a fairly sizable footprint of EMRs, well, broadly, for not just Oracle, but Epic and other vendors in the US, in the way that there hasn't been the same degree of adoption here, for all of the reasons we understand through their policy and investments and so on. But so the net effect of that is, just access to a huge amount of data. And so I guess what it's kind of trying to do is put that data in front of people who need it. So it provides a sort of a platform type ecosystem where you can, basically, depending on what type of partner or participant in this network you want to be, you can get access to that data. And obviously, for people who contribute data, I believe that access or that participation is free. But then for others who then want to consume that data and so use it for research, so universities or academic sort of consortia will pay some sort of a subscription, but then have access to, and of course, all of this is de-identified data, by the way, that's a given. And so I suppose it's about, all of a sudden having access to a far greater volume of data than you might otherwise have been able to do. And what's happened also in the background is that data has all been aggregated and normalised. So, and I believe it's OMOP compliant. So it's, in effect at this stage, obviously it doesn't represent any of the Australian data, but I guess if you wanted to take a subset, you could say that there are representative examples in that data. So, look, I think it's we're kind of excited about it just because of opportunities it could bring, and that it very much centres that notion of partnership, because what it's doing is, you work with, well, we as a vendor, but you as a university and health services, so you could kind of see it sitting quite nicely, say, for a Monash Health Partners, or Adam even, or other institutions in Australia where universities are really strongly investing in and attached to health services, so interested in doing that data. So I guess what it's a little bit like what Soom has been describing about the implementation ready. Obviously, there has to be some things in place to enable that to occur. Clearly, privacy and policy and local governance and so on, that needs to be sort of right from the get-go, so patients understand that they may be contributing their data to such a platform. And so, those sorts of things obviously have to be addressed before one could consider contributing. But I think it's sort of, one of the questioners, I think it was Alex, was asking about that sort of, the translation to impact, if I could put it simply. And, this would be a great opportunity, because I think there is a lot of data already out there in the system, but people being able to get their hands on it is quite another matter. So, that perhaps that's a step in that process.
Thank you, Angela. I mean, that particularly piqued my interest because, I remember sitting in charge of a lot of data at the Alfred 15 years ago, and looking at models like ITB2 from the States and starting to consider, could we do that as a pretty large health service? I could happy to be quite wrong, but I'm not aware of any other vendor-driven initiatives like what you've just described. Because it's very interesting from the university side, we end up having point-to-point conversations with health services. Then all have to broach what tech stack, what's the principles, is privacy okay, who's going to pay for it? Whereas, the vendor inherently is right into the mix of health services data storage because they're providing the technology. As long as those health services support it, then you've got a lot of that stuff covered, which makes it particularly attractive. It's very interesting.
Well, just imagine, and sorry, just before Ashwin jumps in there, that sort of that idea of platform readiness, if there were, dozens or, even hundreds of health services across the country contributing, how, the value of that asset grows. Sorry, Ashwin.
Absolutely. Ashwin, please.
I'm really fascinated, Angela. That's amazing. My question to you is is the data readily available now? And what is the process in accessing that data? And more importantly, from a privacy point of view, you did touch upon it, but the data sharing and all of that, how does that work? And what is the, things behind it? So I get some more information. I'm really interested as a researcher.
Yeah, look, it's happy to sort of keep a conversation going. Again, it's very new. Like, we literally just started to have conversations with our colleagues who look after this engine, if you will. And so we're very early kind of having conversations around what we need to do to ensure that the product is going to be compliant from a regulatory perspective. Obviously, that's really important to us because we can't do anything in Australia if we don't meet, guidelines like, what the TGA might constitute as clinical decision support, or whether it's a medical device. In this case, it's unlikely because it's population type level data, which is currently excluded from, it's not identifiable. So there's that aspect. So that's the sort of work we have to do up front before it can, people can have access to it. But then there's sort of a process by which, there are organisational wide requirements around governance, privacy, cyber, and all the rest of it that have to be met from an organisation's point of view to be sure or comfortable that if you wanted to contribute data to it, that those things were met. And similarly, if you wanted to consume that data. So it goes back again to that sort of the state of readiness from an implementation point of view. And I would say that, that there are, it's sort of like a sliding scale, I suppose, the extent to which you might want to have just be a participant, so you have access to the de-identified data, or you want to sort of have a more active role and be a contributor. So, it's obviously, there's a few things to consider, but it's exciting. I don't know if that answered your question, though.
It did. Thank you.
Thank you.
And fair to say, Angela, many of your customers in Australia, this would still be new to, right?
Of course, yeah. We haven't really been out on the hustings talking about it, but and I suppose it was a bit cheeky of me to just pop that in there today, but I think felt like this was a really great example of where there could be such a partnership, because I guess some of the challenges we have as an organisation is we don't have sort of ready or discretionary funds sitting around that can, say, contribute outside of in-kind to grant applications, or even partner, say, with you to do research that we might want to do with some of our new products. And, that would be one way to manage it, but this, might be another. So, interesting times. And it looks like Epic Cosmos offers something similar there.
There we go.
300 million patients. There you go. That's that's sizable.
Yeah. I've learned something today, so that's good. That's really good. Thank you, Tim.
Yeah.
So Ashwin, and I mean, Suma knows this, obviously, quite appropriately, Oracle, Epic and others respond to their customers. So if customers say they want it, that's a great start, right? You guys are customers, so something to remember. Before I go to the broader questions from the floor, and Angela, I think there's one specifically about your platform, which you might want to answer offline. Tim, some of the things you said before, you were mentioning about, are real world tools working? What do we learn about them? You know, if I had another hat on, I'd say, isn't that what the learning health system's supposed to be about? What do you think of that concept, and do you see it coming to life? We've been speaking about it in this country for a long time.
I think in many ways it is. I think, an overall tool in a learning health system, it's probably a bigger application of the LHS than I've seen done. I think often people look at a very small workflow or, how are we doing falls management or something in the learning health systems rather than did Epic work in a learning health system kind of approach. So I think, I guess fundamentally probably is we're collecting data, we're generating stuff as routine care, we can analyze that and see what's happening, we can make changes, and we can cyclically go around and have a learning healthcare system. But equally, a lot of things at the moment that are being implemented are super hot off the press, all the ambient AI, all the decision support AI tools, the open evidences, all those kind of things. By the time you've gone with a vendor, as you know, Chris, you've spun up a research proposal, you've started doing some work. Already there's been a few other publications around the world, and you're thinking, well, is it worth doing still? Are their findings relevant? If US saved 10 hours of time per clinic per week, is that actually translatable to the Australian paradigm where we have different documentation practices and different workflows and different funding? And do I need to replicate that locally to know that I'm going to get the same benefit? If it's not simple time benefit from the ambient AI, is it a burnout benefit or a mental fatigue benefit or a doctor and patient looking each other in the eyes for the first time because they're not looking at a screen? Well, what is the benefit and how do you measure that? And then how do you communicate it back? And by the time you've done your piece of work and evaluated, is the tool the same? Well, they're on the next version now and the findings are gone. So I think having that agile, having that in a way that we can do stuff well, do we need to change the paradigm from a traditional waterfall kind of research project into a more iterative, agile, embedded researchers? I think ideally it would be more of a learning healthcare system and less of a grant program implementation, evaluation, report goes somewhere kind of linear workflow.
And look, that you raise that issue of differing timelines. I've got a very good collaborative going on at the minute where there'll be a lot of money put into it that we can potentially access as researchers or as a research organisation. But there's two different phases. One phase needs projects done in a couple of months, and the other phase is going to have projects done over 12 to 18 months, and the money is proportionally different. I'm not bothering to engage with the first phase. There's no point. A, the reward isn't big enough, and B, by the time the university agrees to a contract, the whole timeline will have elapsed. So we need to adapt and find ways to adapt on our side. I'm going to go to the online questions for now. So there's that one for Swapna, maybe for you, Angela, as we've said. I might throw this one to you, Seema. There's a question from Anjali about how do you help students be able to get the most out of their experiences in digital health? And I can add in on the back of that as well.
I think this is basically by programs that you're running, Chris, which is the industry-based learning programs, where we could probably embed the students into health services, where we could give them the practical knowledge and the skill set required in this space. And I also think it's also by aligning some of the curriculums as well on what are the skill shortages within the health services that can be adopted into some of the curriculum on the bachelor's program or the master's program that the universities have. I think that is sort of two things I can think that would help students prepare and also fill in the skill shortages that we have within the health sector.
And on that, Seema, I mean, again, you're come from the IT world. If you're looking at what are your departmental, and as an exemplar, your departmental shortages, what skills would you like to have more access to on tap as a CIO?
We have quite a lot of shortage in the cyber area.
Yeah.
In the AI area, I think the AI world is moving rapidly, and I think, like Tim mentioned, the velocity in which we're doing things is quite slow. We have to improve on that because there's ample opportunities in which we can, deliver a simple use case using AI with the technology that we have, and there's a shortage of skill set in that area where we need, probably students coming out with some of the AI technologies and understanding of how to convert innovation use cases into implementation. So I think that's an area. The governance is another area, the data governance aspect that we're talking about, and also aligning that skill set of what we need in that space, and adopting AI into the data aspect as well. I think that's where we find quite a significant shortage. There are other areas like e-health and the coding areas as well, which have quite a lot of shortage in that space. But from a pure ICT perspective, I think these are the areas we really need, and we're really keen with the graduates that we've partnered with. They're doing an amazing job. So I think that's where we can improve on upskilling them.
Thank you. Thank you very much, Suma. So, I mean, I do feel the need. I'm glad Suma just mentioned this, that this program I've mentioned has been going a long time. And I would say that obviously healthcare in Australia is relatively underfunded compared to, say, private industry. And yet, where, profit is everything. It's actually been the private industry companies that have driven that program for several decades. So I guess I'd use that to say if they were not getting value for money from it, they would not continue to use it. And so I think that's an important lesson for inside of healthcare. These students are high-end students. It's exceedingly rare that I hear anything bad from either the student or the supervisor. And I think there's some great opportunities for healthcare organisations. And of course, you're dealing with a huge diversity. So some of the students are doing cyber security, some are doing data science, some are doing, finance and IT. There's all sorts of mixtures. And so there's a process you can speak to me about or come through the link I left earlier about accessing that as an industry organisation, be it a hospital, a vendor or other organisation. Thank you for that, Suma. There's a question from Alex. Probably I'll throw it to you to start with, Tim, and then welcome any other views on it. So do digital health outcomes basically mirror the maturity quality of the organisation relationships of the party or of the parties, or can they on their own catalyse transformation? It's a tricky one.
I think it's an interesting question. I think probably a more mature organisation with more local skill, with better governance, with better leadership, will probably have better access to digital tools and put them in a better way that considers end users. So they're probably going to see, all things being equal, if you took the same products and applied it at an immature hospital and a mature hospital, you get a better outcome at the mature hospital. I think there are some products that bring with them governance and implementation processes and strategy, and some that just give you the disk, as it were, to install and wish you luck. And I think the companies that bring with it implementation practice might do some way of bridging that gap between an immature hospital and a mature hospital, and a bit more of a partnership in terms of spinning something up than simply a software partner, as it were. I think the local ability to evaluate and to really understand what the impacts of their tool is going to be is probably better at a mature organisation as well. So I think overall you're going to do better at a mature organisation with a digital platform. I think at the other end where, an EMR is considered an IT project and the clinicians aren't involved and it's thrust upon them and things, you're never going to have a good outcome with that kind of approach from a change management perspective or a genuine kind of transformation of care perspective. I don't know of many vendors that have kind of managed to get in, although some of the kind of standalone AI platforms at the moment are quite interesting. I can give something like Heidi, essentially going outside of traditional structures. They're not going to organizations, they're going to end users. They're not requiring integration. They're not requiring anything apart from a phone. And they're not requiring people to have a mature digital framework. You go to a single practice private doctor with no IT support or infrastructure, and they're managing to weasel their way in there, and then they're bolting on hiding evidence and everything else. So I think it's interesting that where the product meets a genuine need or can get around the governance and go straight to the end user, you might be able to do stuff. But what the impact of that is, if they then wanted to kind of retrospectively look at their billings or integrate with my health record or do something else, I don't know. And that's where often a hospital will need to consider more than just the one end user. They'll consider all the end users and the external bodies and the government and legislation and the privacy and everything else. So yeah, that's a long answer. I'm not sure I answered it, but.
No, that's helpful, Tim. It's helpful. And look, it's interesting. Again, I'll come back to IBL. It's a situation I'm dealing with quite regularly. I have students who come in and they might be 3 years into a 4-year IT degree or 4 years into 5. And one of the greatest learnings quite commonly is that corporate IT is a team sport, which ties to your last comment. It's all very well for them to look across and see their mates doing a startup. That's a very different world to work in than where most of them will get their jobs, and that is in medium to large size IT departments, certainly their first jobs, and learning about all those dependencies and considerations is very important for them as well. Did you have a comment, Angela? I see you're
I
on
was
mute.
just going to say, I was thinking about risk, and I suppose, Tim's point around scribes is well made because they are solving a real problem. The paradox of EMRs generally is that they, revolutionised the sort of paper world. Everything became digital in most settings, but have just created this enormous cognitive and administrative burden. So it's sort of its own problem it's trying to solve. But I think that we've seen a lot of hype come and go in the technology world, but that's one aspect of AI that's really stuck, is that it is really sticky. As Tim said, people are going out and just effectively going around the governance and using their own, and that of course then gives rise to other types of risks. So it's sort of difficult, isn't it? Because say you're a CEO and you put that, I'm not a CEO, so I don't know what that feels like, but of a large health service, there's a lot of risk that you are trying to manage, and you're trying to manage or at least communicate as not just to your board, but also your constituents broadly about how you're managing that. So I think everyone's got a slightly different risk posture or appetite. And, we kind of, it's a bit like, it kind of makes me think about the, like the commission standards, for instance. They're really accepted, embedded. Everyone has to meet them, certainly in the acute setting, but there are so many different ways in which people are sort of building systems to ensure compliance with them. And, I guess it's somewhat ironic. It's just an indication, I guess, or symptom of the way the health system functions, which is literally, often 1,000 flowers blooming. So, and I just would say accidentally said that I would answer Swapna live when I was trying to type my response into. So I'm sorry about that, Swapna, but I think, it's an excellent point, because obviously the data that you're ingesting, has to be to some extent, sort of not fallible. And I think that the consideration up front before EMRs are sort of contributing, I don't know what sort of local data practices and governance are, but if there's a whole lot of, if the standards aren't good already within the organisation and the way in which people are collecting data, then that's probably going to have a downstream impact. I think what these systems do is give rise to where those challenges are. We're working with a couple of health systems in Australia at the moment where the clinicians have had amazing problems that they want to solve. But in doing so, they recognise that some of that data is it's actually not captured in the EMR in the way that A, it's not captured, but B, also in areas where you'd expect it to be, or there's sort of poor compliance or completion of it. So, it's one thing to have the tools there in front of you, but that kind of, the governance or the data governance and strategy around that is really important as the sort of upstream before it gets to that point. So these are sort of good considerations for people to have. And it's the same, I guess, you may have seen that too with your dashboard work. But, nevertheless, that you're acting on insights. If those insights aren't there, that's also another way to say, okay, well, that's a way we identify that that's an issue and we sort of do something about it. So, but yeah, thanks for the question.
Thanks, Angela. I mean, I think the great thing about any platform view of data is it highlights those discrepancies. Even if you don't know the name of the hospital, if you can go, hospital A seems to have their smoking status all sorted. Oh dear, we're hospital C and we're terrible. We better fix it.
Yeah.
That's actually a valuable thing. You can't fix data until you're looking at it. So
yes, exactly.
I'll give you all just a 10-second heads up. I'm conscious we're coming into the last few minutes. So I'm going to come around to each of you and ask you, what's your sort of take-home message for the audience about how to better strengthen the links between digital health R&D and digital health education and the needs of industry? What would you like to see happen? And maybe that's all university things, maybe it's industry things, but just a 1, 2, 3 quick points each about what you think that needs to look like, what needs to be different. So I might, because Angela's been talking, I'll give her 5 minutes to catch her breath. Suma, do you mind if I go to you?
Oh, yeah, absolutely, Chris. I think if I have to summarize it into a couple of points and what I would like to see from a health service perspective is probably workshops between universities, probably even student representatives, and also the vendors and health services together. So to come up with collective problems that are prioritized, that needs funding. And I think that could be something that the vendors can help us as well, knowing the funding constraints within the health services there. The second thing I would like to see is probably utilizing modern platforms for more of the work that is done within the R&D space. More so a collaboration that we could probably provide those platforms to the universities within the health services where they can actually log in and contribute and work on certain things. So I feel that would be a really good use and also a governed platform that we can both have. And lastly, I think it's just that a good partnership, and what that good partnership looks like between health services and universities and vendors. I think that would be really valuable for both of us to have that channel opening and work together for having a positive impact.
Wonderful. Thank you, Seema. Very helpful. Ashwin, I'll go to you, please.
Looks like Suma stole some of the ideas and thoughts. I mean, I love to think that about partnership, and my main things were access to data is something that I'm really, really keen about. When Angela mentioned that there is available data, why do we still go through a lot of these issues and talk to different people? And we seem to be working in silos rather than from an ICU data is not linked to the medical data. It's not linked to the cardiothoracic data. It's not linked to the cardiology data, for example. How is it possible to streamline all of that would be something that I would love to answer at some stage. But from a R&D point of view, I think digital health does not fail the technology if the technology is weak. I mean, I think what needs to do is we need to address it to the real people to get it all implementation ready. So that's my key thing to add. Thank you.
Thank you very much, Ashwin. Completely agree. Completely agree. I try to push this even onto our students, who are put into subjects to come up with an innovative idea and say, but how do you know it's a worthwhile problem, and who have you spoken to, and have you looked at this and looked at that? And that's fun and easy for me to do, but it's a constant thing to get them to get out of what looks like a cool tech thing into what's the actual problem that they're going to solve and what's worth solving. Tim.
I think agile partnerships is what we need. So us working better together and being flexible in the way we work. And I think as part of that, removing a lot of the traditional barriers to work together, whether that's contracts, data sharing agreements, honorary employment statuses. Well, obviously that all needs teasing apart, and it's not going to be a simple thing to sort out. but
Yes.
it's the same issues every single time we try and do anything. And you spend hours and hours with the lawyers and the Office for Research and the contract
Yes.
people and
Yes.
why? It's the same question every single time. It's like, no one's profiting off this. No, the IP is very unlikely to go anywhere. And if it
That's
does,
right.
I guess we can sort it out at the end.
Uh,
Yes, it's de-identified. Yes, it's okay. Come on, let's get on with this. So I think having a way for us to do that better and more efficiently and remove some of those barriers, and then for us to have more of a partnership and be a bit more agile.
Completely agree. Thank you, Tim. Thank you. Angela, your
Look,
takeaway points.
I don't know if I haven't got anything sort of really distinctly different from what others have said, because they're all really well made and very, I guess, fundamental points. But I would just say trust and alignment. Well, establishing the trust first, I think, is a really important one. So that's it's underrated in some contexts, but then just the alignment of goals and outcomes. And so having, I think, cognizance of the environments you're operating in and really setting expectations up front. I mean, I think a lot of things go wrong when there's just a complete kind of misalignment of where those expectations were, and finding a way to have both articulate that and document that can be two separate things. But they're my sort of takeaways.
Yeah, and look, I literally in the last few days, Angela, had a very pleasant conversation with a person I somewhat know. They wanted to pitch some work with us, and on the point of expectations, I said, "Do you have any funding towards this work?" And they said, "Oh, I have a figure in my head, but it's probably different to the one in your head." I said, "Can you please take it out of your head so I can put it in my head, and then we can have a conversation about it?" But you're right. It's just trying to, and you need a bit of trust to do that, to be able to have an
you
honest
do.
conversation. Yeah. Thank you very much to Angela Ryan, to Associate Professor Ashwin Subramanian, to Suma Shivalingaya, and Dr. Tim Fazio very much for all your wisdom and insights this afternoon. It's really appreciated. And I must also thank very much the great FIT marketing team, so Heather Beveridge and Lucas Sharp behind the scenes, who help us run these sessions, because part of the reason you don't see my head for a while is I'm furiously doing other things behind the scenes to make sure everything's in line, and I don't want to distract you by jumping about, but they help enormously with getting the session set up and with making sure they run well on the day. So thank you very much again, everybody. We've got a whole day in-person only session and on the 29th of June at the Clayton campus about the pointy end of AI and how we actually get it to work in the real world. And those of you who've heard about today's session will usually be on the same channels that you will hear about the opportunity to attend that as well. So thanks again very much, everyone. Have a good day.
Thanks for the opportunity.
Thanks,
Great
Chris.
sharing, Chris, as always.
Thank you.
Good to see you
Thanks,
all.
Chris.
Thank you.
Bye.